Can start now. Thank you very much for invitation. It is my honor to coordinate with Dr. Saira this workshop. My name is Jacek Gronwald. I came from Hereditary Cancer Center from Poland, Szczecin. So it is located in northwest part of Poland, and we have, I think, one of the largest registry of BRCA carriers. So, but about it a little bit later. I am delighted to welcome to pre-symposium workshop cancer research session, which is a part of 22nd already. It is so big history. Yes, second annual Shaukat Khanum Cancer Symposium. So it is already long history, and welcome everybody. Thank you for coming, and welcome this who are hybrid online. And I think our presentations will be very interesting for you and inspiring.
I'm Saira Salim, and I work at Basic Sciences Research Department in Shaukat Khanum Memorial Cancer Hospital. My area of research are cancer biotomics, and I'm very happy that I'm here to co-host this session, cancer research session with Dr. Yarsik. It's my honor, and I would like to invite our first speaker, Dr. Hamad Naveed. He is the Director, Computational Biology Research Lab, National University of Computer and Emerging Sciences, FAST, in Lahore, Pakistan. He's a professor of computing, and his interests are basically in artificial intelligence, machine learning, and to understand the diseases, including cancer, through the computer-aided softwares. And today he will talk about a few of the recent advancement in this field and his own work. Over to Dr. Hamad Naveed, please. Thank you.
Thank you, Dr. Saira, and the co-hosts, and thank you so much for inviting me to the 22nd, as I'm been told, annual Shaukat Khanum Symposium. I'll be talking about computer-assisted, predominantly data science, AI-assisted digital pathology. I'm currently at the National University of Computer and Emerging Sciences, and I had the Computational Biology Research Lab. So I'll actually be sharing the journey with Shaukat Khanum. So we started about a couple of years ago about how to take this digital pathology forward. So most of this will be in a very local context. We will talk about state of the art and how we are with respect to the rest of the world. But in our local setting, there are a lot of constraints. How do you go about working in those constraints as well? So with that, let's get started. So just a brief background. So we started our journey in about 2018, where we started to look at digital pathology or whole slide images of breast cancer. And as you know, 1 in 8 women in the US will develop breast cancer at some point in their life, and early detection improves survival. The numbers are exactly the same in Pakistan as well. Currently, the region of interest or the focus point on the whole slide image is manually obtained. You search around the microscope and you try to find the region which best gives you the diagnostic accuracy. And detection currently through subjective consensus of domain experts. A couple of pathologists sit together to try to come to a diagnosis. And even when you sit together and come to a diagnosis, we actually know that 70% of the time two pathologists don't agree on the same thing. So there is a need for a fast and accurate third-party opinion that's not subjective, that is not based on the fact that somebody was trained at Shaukat Khanum or some part in interior Sindh. So which is where we wanted to add the computer side, the automated detection part. So we started off with looking at the 15th International Conference on Image Analysis and Recognition, ICIAR, that actually publishes whole slide images of breast cancer every couple of years and asks the computer science community to come up with algorithms that can either detect mitotic cells or classify the the whole slide images into benign, normal, benign, in situ, invasive, different classes. So we started looking at it, and why did we get interested? Because I actually spent my postdoc and my research career most in the West, and where we actually did not have too many underage or teen cases of breast cancer. But when I landed back in Pakistan in 2017, we were really surprised when we were talking to Shaukat, Khanum and Shifa that a lot of teenager breast cancer patients were there. So these statistics are just from WHO 2020, where about 34,000 breast cancer patients were diagnosed, and almost half of them were not able to survive. This is in comparison to, this is just a 50% survival rate in comparison to the 90% survival rate worldwide. So this is a very huge problem here. Somehow, some factors related to awareness and diagnostic accuracy are contributing to the less survival rate or late detection. So one of the major things when we look at it from a computer science perspective is when you digitize these whole slide images, they are huge images. They are not small images that we come across in our daily life. These images can be as big as 1 gigabyte. So just to put that in perspective, a normal laptop has a 16 gigabyte memory. So if you just want to load images, you will probably not be able to load 15 at one time. But for computer science algorithms, in order to find patterns in these images, we need thousands of them. So this is a huge challenge. How do you deal with such large images, and how do you come up with patterns that are available? So what traditionally we do is we divide the image into small pieces. And what that results, so if I had 10, in this case, 10 whole slide images, if I divide it into small parts, I can have several small images, which we call patches. But the issue with these is that our annotations are usually at image level. So the whole of the tissue is either annotated invasive, but there are several parts within the tissue that are actually normal. So if you annotate them as invasive as well, that will basically confuse all the automated detection algorithms. So this is a huge challenge. The other challenge that we have is we don't have an equal distribution among all the classes. If you look over here, 75% of the patches are normal, and about 22% are invasive, and we have very few in situ and benign parts. So if I had a very dumb algorithm and I just output all of it as normal, my accuracy will already be 75%, but it will be useless. So we have to come up with things that looks at where we don't have enough information, and we try to predict the same thing as well as where we have some information. The other thing that we don't have in Pakistan is basically a huge computational power. If I was in University of Chicago or somewhere else, we will have a huge high performance computing center. I could just load thousands of these images directly into the memory and start looking for these things. But because we have limited memory, I cannot even have a very hi-fi algorithm that can save a lot of information. So this is actually the journey of how complex your algorithm is in terms of number of parameters that it saves in millions. So most places in Pakistan cannot deal with any of this algorithm over here. We have to deal with few number of parameters. So can I do something with which is as basic as which has less than 10 million parameters and looks at such big and complex images? So this is what we started trying to do. And actually, it turned out that it's actually not very hard to, if I just want to classify the image as normal, benign, invasive, and in situ. This is just that smaller algorithm. It actually achieves about 89% accuracy. But the other, and similarly, other people, if I use any other algorithm, it will achieve a very similar amount of accuracy. So, but when I try to ask what is it exactly that it is looking at, and if I try to identify, okay, it's this patch or this patch that is giving me this accuracy, that is where the problem is. If I treat it as a black box and I just give it to the clinician, they will ask me, what are you looking at? So once I started looking at what is the part that is causing this, the overlap between the important part or the invasive part and what I thought was invasive was only 11%. And if I look at some other algorithm, it was even worse. So what we came to the conclusion was, because we were not looking at the whole image together, we had a limitation of not being able to look at that. Somehow we were losing some of the information that was around the image, and we only had the local information, and somehow we had to add the global information. So what we did was we just took the probabilities of each patch from this part and we resized the image to get the global image. So now I have 4 probabilities coming from each patch. And I also look at the global image with the resized one. This is a shorter, smaller version that I can load. So this will give me the global and this will give me the local information. And once I do this in a 2-step manner, I take my overlap with what was important to 70%. And in this ICIR challenge, the 2 pathologists that had annotated also had only an overlap of 70%. So we were almost as good as 2 pathologists agreeing with each other. So these were our first results. Just to show you some examples. So this is the ground truth that was given to us. If I just looked at local image, you can see what is important. I've just highlighted that in black. It's a lot of noise. Whether I use my algorithm or some other algorithm, they don't really perform very well. But once I start looking at the global information, my algorithm is almost as good as this one, but others also do a pretty good job. And these are some of the examples that we have. So the leftmost is the ground truth. The middle one is when you only look at local information, and once you add the global one, you start getting a very good overlap of invasive characteristics. Just some more examples. So we do slightly bad in some places, but there's a lot of improvement that's required. But that's the gist of it. You don't just need to look at local. You have to somehow incorporate the global tumor microenvironment or neighboring mitotic cells. In isolation, if you're looking at just a few cells, it's hard to detect what stage of cancer it is. Okay, so that was all international data. It's very good hunky and dory to just grab some data from the internet and start looking at it. But it's actually very well known that these deep learning or computer assisted models do not translate very well when you take some other data set from another hospital. When you take another scanner, they will not work very well. So we wanted to do something that worked here in our local setting. So for that, we first of all had to set up our infrastructure. How do you digitize? There were actually no digital images available in Pakistan. So we started this journey with Shaukat Khanum in 2020. And we first had a microscope that again gave us local information. It's not giving me the whole slide. I could only extract patches out of it. And we started working with that, but eventually we got our first digital scanner for which we were able to produce our own whole slide images in collaboration with Shaukat Khanum. The challenge that at this stage we had was, okay, now I have a digital image which is 1 GB. How do I take it back to the pathologist so that they can tell me these are the mitotic cells or these are the blood vessels? How do I get that annotated? For that, we had to build a new annotation portal, which basically transmits it over the internet. It's a very easy local solution where you only transmit the part of information that is in focus. You don't emit the whole 1 GB, and it very easily the pathologist can just highlight which parts are important. So we have a formal IRB approval with Shaukat Khanum for the past couple of years, and we'll be working with them. So and just to show you that actually this is important. So these are international challenges that the biomedical community throws up every year, either in the MICAI conference or some similar other conferences. In this, they were looking at how does your algorithm performs when you have tissue samples from different scanners, various tumor types, or various lighting settings. So this is 2021 challenge. We have a similar challenge in 2022, where actually they even added different species. So if you're trying to detect mitotic cells, will it matter if you have a different species? And you're looking at the mitosis in different cells or in a different organ or a scan from a different scanner? It actually does not work very well for computational algorithms. They try to figure out certain. So for example, just if I compare Shaukat Khanum and Shifa International, the staining quality is slightly different. Usually I get slightly more purplish pictures from Shaukat Khanum and slightly pinkish pictures from Shifa. And because I'm not telling my algorithms or automatically trying to learn some features, it starts picking up the colors. So if it's learning purple color, dark purple is for my mitotic count and some shape. When I translate that to Shifa, there is no purple, not as dark purple color. So it starts making no sense at all on that data. So we have to come up with these generalized solutions for that. So this is just one example of what we get as an input image, where if you're looking at mitotic count, They are circled nucleuses which are mitotic, and the rest are normal. Similarly, we've been looking at style transfer. For example, if you're trying to predict the HER2, if you're trying to get the HER2 status to come for the diagnostic of breast cancer, is it required that you do immunohistochemistry, or can you just look at the H&E staining and come up with that diagnosis? And actually, I'll show some results. So in this case, we are given both the H&E stained and the IHC stained, and can our algorithm learn something from the H&E stained image to try to predict the HER2 expression level, and we don't have to actually go towards the IHC staining. So this is what we do. So as I said, there are actually 3 methods that people do. The first one I just showed you. You actually, instead of looking at the whole thing, you convert into small patches and try to infer something from that. The other thing is, okay, I don't have the resources, I just resize everything into small. What I showed you was something from here and something from here. But then in the last few months, we have come up with a new algorithm where we can actually, using the same hardware, load the whole image together, and we don't have to do that. And how do we do that actually? I know this is not a very technical audience, so I'll just give you a very brief overview. So what we try to do is, because we are not telling any feature to our computer, the computer is learning all the features. Uski shape kaise ho, how will the shape look like? What would be the color? So that we usually do through convolutional blocks. It's basically looks at some things around it. If everything around it looks in an elongated shape, and I tell it's a mitotic cell, it starts learning that around it. But I have to keep doing that a lot of times. For that, I need to save a lot of parameters after each block. Actually, the cost of the space is because of these parameters. It's not because the image is, as I said, image is 1 GB, but my memory is 16 GB. So why can't I at least load one whole image together? At the moment, we can't even load one. So we actually don't save these parameters. And because these images are huge, the loading time into the memory is also huge. So what I do is I take the loading time one time. I'm only loading the image one time, and I'm going to recalculate these things all together, which saves me a lot of time. And actually I can see the whole image together, so I can look at global features, not just local features. So this is in the past that people were not able to do that. We have done in the last few months, and I'm going to show you some data, some results from Shaukat Khanum data. So we had scanned about 300 colon cancer whole slide images with Shaukat Khanum. There were 61 metastatic, 77 non-metastatic, 72 normal, and 77 polyps. Using this method where I'm looking at the whole image together, this is the one that ours where we don't have the limitations. We can have an F1 score of about 81. If I just look at the small local regions, which is the patch-based one, this is what you get, about 15% accuracy, which is almost nothing. It's less than random. If I just lose a lot of information and resize the image into a smaller image, you can still get about 60%, but this is a huge advantage if you don't lose that information and look at it in a very high magnification. In terms of time, as I said, because I'm recalculating a lot, but I'm not loading it. This epoch is what we say, how many times did I go through the whole data set. So it takes me about 31 hours to sort of get to a one converged value where I can say that now my algorithm has learned something. So this is in comparison to traditional methods, this is almost the same. So I'm not losing on time, and I'm gaining on a lot of accuracy here. Similarly, the data set that I showed you here, this is an international data set, breast cancer immunohistochemical image generation challenge. In this, we were given about 344 IHC 0 images where there was no HER2 expression, 1 plus expression of 1600, 2 plus 2952 images, and 3 plus 1888. For this, we actually have a very good 98.4, which is almost a perfect score of, I can tell just looking at H&E stained images, the expression of HER2. So you don't need to go to actually IHC in this case. Again, the time comparison over here is almost the same, 33 hours to get to a point where I can start telling what the image looks like. And just to briefly tell you, these are not the only things that we have worked at. So we look at a lot of international challenges. This is the diabetic full tussle challenge in the MICAI conference last year, where you were given images of injuries on the foot, and you had to classify whether you need to, whether it's infected, whether you would need to amputate it, and all that. We were third in this challenge. Similarly, this was the hot challenge where you were looking at. We were given X-ray images, and you had to look at whether the X-ray showed you a COVID patient, a normal, or a pneumonia patient. We were actually second in this one as well, with a 96% accuracy. Just to summarize all of this, I hope I do have time. Yeah. So we have, in the last couple of years, together with Shaukat Khanum, we have produced the first digital repository of high resolution H&E stained images from Pakistan. We have scanned a total of almost 500 images right now. We have come up with resource appropriate computational framework, so we don't need very high performance computing like the West. We can use the computers that we have available over here and be as good, or our performance is similar or better in all cases with the state of the art. And we are actually trying to package this into a clinically deployable diagnostic assistant, which will be helping the pathologist improving their work efficiency, efficacy, and time management. So with that, I'd love to take any questions that you have. Just to give all the credit, we have a large group of people, very diverse, male, female, masters and PhD students who basically work on these challenges together. And I would like to, in the end, thank the places that I've trained at and the funding bodies, HEC, NCA, NCBC, Fulbright, National Science Foundation of China. That's pretty much. I would love to have any questions.
Okay, okay, so questions will be. Okay, so I would like to introduce the second speaker, and our second speaker is Dr. Asim Amin. He's consultant oncologist currently working at Atrium Health Levine Center Institute, and he's associate professor at Wake Forest University, director of immunotherapy in United States. Thank you for joining us today. Over to Dr. Asim.
Good morning or good afternoon. I thank the organizers of the symposium for this kind invitation to join you today. My name is Asim Amin, and I direct the immunotherapy program at the Levine Cancer Institute. In the next 20 minutes, what I will attempt to do is to share a truly rags to riches story that pertains to treatment of advanced kidney cancer, where we had no options, and now we have so many options that we don't know how to choose. So let me share my screen with you. And so this is the extent of the problem. In the US, the incidence of renal cell carcinoma has been increasing over the past 5 years, and the mortality that had gone up until 2018 has slowly started coming down. And this, we think, is at least in part because of the effective treatment options that have been developed. The world incidence for kidney cancer is about 430,000 cases in 2020, and the world mortality was about 180,000 cases. So not an insignificant problem. Here's the options for systemic treatment of advanced kidney cancer. 1992, this was the only option. The only option was high-dose interleukin-2 that required administration in a very controlled environment by a very highly trained staff and for very fit patients. So it was not really applicable to almost 3/4 of the patients, because we know advanced kidney cancer can result in a lot of morbidity. So then in 2005, a new class of drugs came by, and these were the tyrosine kinase inhibitors and the mTOR inhibitors. So now targeted therapy made its way into this therapeutic space after we found out the importance of VEGF inhibition in this setting. And we'll go to that in a little bit. 2015 saw the advent of modern immunotherapy with nivolumab and subsequently the combination of PD-1 and CTLA-4 inhibition, and more recently the combination of tyrosine kinase inhibitors, pembrolizumab, axitinib, cabozantinib, and lenvatinib, in addition to immunotherapy. The most recent approval for advanced renal cell carcinoma was belzutifan, that is for those individuals who have the VHL syndrome, and is under current investigation for other folks who may have the VHL mutation. So from nothing to a palette full of options, let's go through them and see how best to use them. This is prior to immunotherapy or prior to targeted therapy. These were the survival curves. So this is coming from the West Coast data, where the 60-month or 5-year survival was in the range of about 20%. Now with modern immunotherapy, this is data from the Checkmate 214 study using CTLA-4 and PD-1 inhibition compared to sunitinib in the gray curve, and red curve as the immunotherapy, where we now have 5-year survival at close to 50% or 48%. So again, not to truly compare, but try to get an estimate of what the benefit has been over time. This is the change in overall survival over the past 15 years, where the stage 4 patients from about 20% mark are now close to the 50% mark. So truly a significant change in the natural history. So how did this story all start? Because we only had high-dose interleukin-2. Then in 1993, what was found out on the left, you can see chromosome 3 that has the von Hippel-Lindau gene. The von Hippel-Lindau gene codes for the von Hippel-Lindau protein that normally at normoxic conditions should destroy a transcription factor called HIF1 alpha that is responsible for multiple molecules, including vascular endothelial growth factor that contributes to new blood vessel formation and growth. So if the von Hippel-Lindau gene is mutated, as it is with clear cell carcinomas in almost 80% of the cases, then the von Hippel-Lindau protein doesn't work, and that leads to these growth factors being produced, and they can, so on the left you can see the tumor cell, and on the right you can see the endothelial cell or the pericyte, new blood vessel forming cells. So these growth factors will now be released, and they will go and bind to their respective receptors, tyrosine kinases on the endothelial cells, including the vascular endothelial growth factor, the platelet-derived growth factor, the fibroblast growth factor, and that results in new blood vessel formation, and the new blood vessel formation now feeds more tumors. So the new class of drugs that came around in 2005 were the VEGF tyrosine kinase inhibitors that included sorafenib, sunitinib, pazopanib, axitinib, and more recently cabozantinib and tivozanib. Lenvatinib does VEGF inhibition, but it also does fibroblast growth factor inhibition. So all of these are oral agents, small molecules that can inhibit new blood vessel formation. But that's not the entire story. The VEGF levels in the tumor can also suppress the immune system. So combination of these with immunotherapy can result in a more meaningful immune response. We'll look at that data in a second. Around that time, when the VEGF tyrosine kinase inhibitors came around, what was found out was that mTOR, the mammalian target of rapamycin, is an important target in renal cell carcinoma because activation of this results in these cells having growth advantage. So temsirolimus and everolimus then are mTOR inhibitors got approved in this setting. These are the survival curves based on the impact of tyrosine kinase inhibitors. I showed you the overall survival for stage 4 disease earlier on with advanced kidney cancer. That was about 5-year survival was close to 20%. And this is the impact of tyrosine kinase inhibitors. You can see based on the risk factors using the IMDC criteria, after first line treatment, the overall survival is almost 75% at 24 months for favorable risk and 50% for the intermediate risk patients. So follow-up data for this is being presented. In the second line treatment with tyrosine kinase inhibitors, we again see the overall survival curves to have clearly increased from that 20% overall range. This is after second line of treatment. So that was the impact of tyrosine kinase inhibitors. In the 80s, 90s, what we saw was insights into the immune system. We found out that the T cytotoxic cells or the T killer cells have a whole bunch of on and off switches on their surface. So these are the on switches on the right side, on the left side, CD28, 41B, VOX40, and so forth, and the off switches on the right side, including CTLA4 and PD1. So either blocking the off switches or exciting the on switches, we can have the T cell turned on so that it can go and kill tumor cells. Let's look at that data. This is how an immune system, how the immune system will respond to a tumor, or kind of a cartoon to show that. Here's a tumor antigens or tumor proteins coming in. They're taken up by antigen-presenting cells. These are the specialized cells of the immune system, including the dendritic cells. They now process the tumor antigens, attach it to self-HLA molecules, and then re-express it in the context of their self-HLA molecules, either class 2 antigens or class 1 antigens to T helper cells and T cytotoxic cells. The T helper cells, in response to that, will start making cytokines, including interleukin-2, that can now go and attach to the effector limb of the immune system, that is the cytotoxic T cells, and stimulate them. We know that as the T cells get stimulated, nature has checks and balances in place. One of these checkpoints or inhibitory checkpoints is the CTLA4 molecule, or the cytotoxic T lymphocyte antigen 4. So here's an activated T cell, and then the CTLA4 molecule starts appearing, so it gets switched off. It put curbs on the T cell. Using an anti-CTLA4 antibody can now change that and prevent this T cell from switching off. The T cell now is again activated and is trying to get to the tumor. In the tumor, there are other immune suppressive influences, including a protective molecule called PD-L1 or PD-L2 that can now attach to the PD-1 or programmed death molecule on the T cytotoxic cells and result in those T cells getting switched off. So there's this exhausted T cell now that can't do anything against the tumor. Using either an anti-PD-1 antibody or an anti-PD-L1 antibody, blocking this PD-1 access will result in this exhausted T cell to come out of exhaustion and be pulled into being an activated T cell that can now go and kill the tumor cells. So using this approach, we started looking at both the anti-CTLA-4 and the anti-PD-1 antibodies. Here's the tumor cell or dendritic cell on the left side and the inhibited T cell on the right side. Using nivolumab, we could block that PD-1 access. We also saw that for the PD-1s or the immunotherapies to work in the tumor, they need to have a favorable immune environment in the tumor, and that is usually inhibited by VEGF that can inhibit the dendritic cell function or can promote the generation of regulatory T cells or myeloid-derived suppressor cells. So therefore came on the concept that can we use a tyrosine kinase inhibitor to block these inhibitory influences in the tumor and have the immune system work better. This was the first phase 1 study that was done using sunitinib, that's a tyrosine kinase inhibitor, plus nivolumab, a PD-1 inhibitor, versus pazopanib and nivolumab. And in this study, what we saw was an overall response rate of 52% in the sunitinib plus nivolumab arm. This phase 1 study also looked at using the combination of immunotherapy with CTLA-4 and PD-1 inhibition. So at that point, the direction went into getting that trial finished first. So the first trial, that phase 3 study that looked at ipilimumab plus nivolumab, that's CTLA-4 plus PD-1 inhibition against a tyrosine kinase inhibitor, that's shown here in gray, that's sunitinib, versus immunotherapy in red, showed an overall response rate to be significantly improved with immunotherapy over tyrosine kinase inhibitor. And these responses with immunotherapy are durable. So those long-term responders that did have a response, at 5 years, 73% of those folks shown here in red did not have their disease come back, and their response continued. 50% of these individuals who were treated with dual immunotherapy did not receive any subsequent therapy, thereby meeting that arbitrary definition of cure. So as I showed you before, there can be inhibitory influences because of VEGF in the tumor microenvironment. As that study with ipilimumab plus nivolumab was completing, now looking at VEGF tyrosine kinase inhibition with pembrolizumab and axitinib came through. And the study reported an overall survival of 74% at 2 years versus 65% for sunitinib alone. So this was statistically significant and led to approval of pembrolizumab plus axitinib. Avelumab is a PD-L1 inhibitor, another immunotherapy, and now a clinical trial done with that plus a tyrosine kinase inhibitor, axitinib, showed that the overall progression-free survival was improved in favor of the combination with avelumab plus axitinib, shown here in red, versus tyrosine kinase inhibition with sunitinib alone. So this combination was also approved by the US FDA. Newer tyrosine kinase inhibitors are coming through. One of these included cabozantinib that had a wider spectrum of activity and blocked AXL and MET as well. So now the 9ER study was designed to look at nivolumab, that's PD-1 inhibition, plus cabozantinib, shown here in blue, versus sunitinib in red, and again, the same outcome with improved overall survival with the combination immunotherapy plus tyrosine kinase inhibitor. So this is also now approved. The most recent approval has been the combination of pembrolizumab plus lenvatinib, that is a multi-kinase inhibitor, and showed that in comparison to sunitinib, the red curve shown here, black curve shown for sunitinib, showed a survival advantage, thereby getting pembrolizumab plus lenvatinib approved. So if we look at all of these approvals now, how do we kind of decide? So in the blue is the experimental arm, in the red is this sunitinib or the tyrosine kinase inhibitor arm. So you can see the sunitinib response rates in various studies. On the left is the Checkmate 214 study with CTLA-4 plus PD-1. And then subsequently, we have the tyrosine kinase inhibitor plus immunotherapy versus sunitinib. The response rates vary anywhere from 42% to 70% with the combination of pembrolizumab plus lenvatinib shown on the right side. So how do we choose what to use for our patient? Now, here what I did again was I tried to superimpose the overall survival curves that based on the data we have. So the red or maroon out here is the survival curve from the immunotherapy study with ipilimumab plus nivolumab, showing a 43% overall response at 5 years. The data for the tyrosine kinase inhibitors plus immunotherapy is still not quite there yet. We have the 36-month data available, and those curves appear to overlie the immunotherapy curves. But what we don't know is what is going to happen to the blue curve with pembrolizumab plus axitinib as we move forward. So that's the extent of our insight into a comparison. So there we go. These are all the different tiles that are now available in this therapeutic space. So how are we going to choose what to use for the patient sitting in front of you? Here's my take on that. As best, try and tailor the choice based on patient characteristics. So what does that mean? You know, is this a patient who has small volume disease or has high volume, very symptomatic disease? Do you need a response in a hurry, or do you have time for immunotherapy? Because generally immunotherapy will take a few months or weeks to kick in. So do you need a response in a rapid fashion? Perhaps those are the folks who should be treated with a combination of tyrosine kinase inhibitor plus PD-1 inhibition. And the highest response rate that we know of at this point is with pembrolizumab and lenvatinib. For those who may have smaller volume disease, who have time for immunotherapy to kick in, because of the durability of response that we know of, they may be reasonable candidates for immunotherapy with ipilimumab and nivolumab. Look at the comorbidities or other sites of disease. The tyrosine kinase inhibitors will lead to bleeding issues, will lead to clotting issues. So if somebody already has a cardiac issue or vascular issues, they may not, within the last 6 months, they may not be the ideal candidates to start off with a tyrosine kinase inhibitor. Folks who may have underlying autoimmune disorders, so Crohn's disease or ulcerative colitis or rheumatoid arthritis, these are folks who may not be optimal candidates for immunotherapy. So these are the folks who you may need to think about in terms of a tyrosine kinase inhibitor. There are special populations there where you will have to look at tailoring treatment, especially an example is a post-transplant patient. So post-transplant, you can't use immunotherapy because what will immunotherapy do? They will likely result in rejection of the transplant. So these are folks you will again have to think about using tyrosine kinase inhibitors or mTOR inhibitors. Remember, everolimus is a cousin of sirolimus that is used in the transplant setting for immune suppression. So you will have to work with their transplant people to tailor that treatment. We know that toxicities, whenever we use a combination of an immune checkpoint inhibitor and tyrosine kinase inhibitor, the toxicity is generally driven by the tyrosine kinase inhibitor and not really by the immunotherapy. So the choice of the choice of tyrosine kinase inhibitor becomes important. Axitinib has a short half-life. Cabozantinib has a long half-life. You know, is the patient elderly, you want to be able to titrate your treatment effectively. Maybe you need to use something with a short half-life. So these are all important considerations when making the choice of the tyrosine kinase inhibitor in combination therapy. We know that combination therapy generally has more toxicity than monotherapy, but that does not mean that monotherapy does not work. So, you know, consideration for, yes, the newer, more, what look to be more effective and sexy options may not be for all. You know, it may just be that you need to use monotherapy for a patient who's elderly and who's not well with multiple comorbidities. What is the best sequence? We don't know that yet. We don't know because the sequential studies have not yet been done. That is something to be determined. So I wanted to share this rags to riches story with you, and I thank you for your attention. So
Much for very interesting talk. Questions will be later, yes. And if I can, so I would introduce the next speaker. The talk will be the role of P2X7 receptor in neuroinflammation and cancer. And talk is from Dr. Khalid Farouk. He's a lecturer in the Department of Neuroscience Research, Imam Abdul Rahman bin Faisal University, Dam, Saudi Arabia. Thank you for joining us today. Dr. Khalid, the floor is yours.
Hello, Assalamu alaikum. My name is Dr. Khalid Farooq. I am working in Department of Neuroscience Research in Imam Abdurrahman bin Faisal University in Saudi Arabia. Today's seminar is about role of neuroinflammation in glioblastoma multiforme and major depressive disorder. So, beginning with the problematic that mood disorders are very common with cancer, and major depressive disorder is one of the most prevalent mood disorders, and glioblastoma multiforme is again one of the most common cancers in among all the different cancers of the brain, and it has very bad prognosis, and they have got a very strong comorbidity. So it's pertinent to explore this association and look for better therapeutics than those that are available. The overlying pathophysiology of major depressive disorder and glioblastoma is revolves around inflammation. Neuroinflammation has been implicated in depression, and neuroinflammation has been also found to be playing a role in the advancement of glioblastoma. And there are some pathways which are shared between these two diseases. For example, nuclear factor kappa B, MAP kinase, JAK-STAT pathway, and this is where we aim to look for some treatment modalities, some therapeutic options that can help us make the life of people with glioblastoma and major depressive disorder better and prolong their life expectancy. So as the current state of the art treatment therapy goes, we have GBM diagnosis, and we go for initial radio and chemotherapy, and that's where the moderate depressive symptoms arise, either because of blocking neurogenesis or because of, of course, the social effect of the diagnosis. And then when chemotherapy starts, we usually have full-time major depressive disorder diagnosis because of the inflammatory effect of chemotherapy, and of course the progression of disease. So we've been working on thymoquinone, which is an anti-inflammatory compound. It is the active component of Nigella sativa kalonji, or we call it in Arabic Habb al-Baraka, and it has been found to have neuroprotective and anti-cancer, anti-inflammatory, and antioxidant effects, and it is widely considered to be as cardio and neuroprotective and anti-hyperglycemic. So we did initially some research work with the cell lines, and then with some animal models of glioblastoma and depression. So initially we did cytotoxicity analysis, cell cycle analysis, and effect of thymoquinone on metastatic potential of these cancer cell lines. So our first results showed that effect of thymoquinone on cell viability in U87NG cancer cell line was very significant, and it showed that the cell viability was decreased in the presence of when it was treated with thymoquinone. Next, we tested the effect of thymoquinone on cell cycle regulation, and there we found out that thymoquinone and fluoxetine, they induce cell cycle arrest. When we started checking antidepressant potential of thymoquinone against acute stress, we used the concanavalin A model, which is an acute stress model of depression. We use four-stream test, tail suspension test, and elevated plus maze test, and in all of them, thymoquinone worked very well to alleviate the behavioral despair induced by the acute inflammatory stress. Moreover, in the same model, we also tested the anxiety parameters like the novelty suppressed feeding test, which is used to determine the anxiety in the animals, and also the elevated plasmase test. And again, thymoquinone treatment decreased the anxiety, showing its anxiolytic potential. Then we used a stress-based animal model of depression, where we gave unpredictable chronic mild stress in the mice. And again, the results showed good potential of thymoquinone in treating the behavioral despair associated with chronic stress-induced depression or anhedonia. We tested different markers, inflammatory markers in the brain. For example, initially we tested tumor necrosis factor alpha expression in the hippocampus and amygdala, and as you can see in the results, that treatment with thymoquinone decreased the TNF alpha expression, which was increased by fluoxetine. Again, UCMS induced an increase in the expression of interleukin-1 beta, which is one of the inflammatory cytokines, and thymoquinone reversed this change in brain in the hippocampus and amygdala. Similarly, the expression of IL-6 was also moderated by thymoquinone in the same animal model. UCMS induced a contrasting effect on neuroplasticity marker, the brain-derived neurotrophic factor, which was compensated by thymoquinone in the hippocampus and amygdala. So we also tested the effect of thymoquinone on the NUN and the Ki67 expression in animal model. These are the markers of neurogenesis inside the brain, and the antidepressant activity of thymoquinone was tested because of its anti-inflammatory activity, which remained independent of neurogenesis. It did not increase or alter the neurogenesis markers. Neurogenesis is one of the prime mechanisms through which current therapeutic regime works in depressed subjects. We tested one more time the antidepressant effect of thymoquinone in the GBM mice model, the mouse model, which was injected with glioblastoma cells and developed glioblastoma, and the evidence of depression was found. But the social interaction, the deficit of social interaction was reinstated by treatment with thymoquinone. Similarly, in the novelty suppressed feeding test and elevated plasmase test, the cancer suffering mice also seemed to improve as a result of treatment with thymoquinone. Tumor biopsy of the tumor and a neurogenesis marker in Ki67 expression in the hippocampus of the brain also showed that there was increase in proliferation, which was decreased by thymoquinone. Thymoquinone also decreased the TNF expression in the GBM mice model, and which is also again attest its anti-cancer effect. So IL-6 expression was also increased in the tumor area, and which was also decreased by thymoquinone, and the same effect was noted in the interleukin-1 beta. So you can see that these inflammatory cytokines are common between depression and cancer, and thymoquinone is working effectively to reverse the changes both in tumor as well as inside the brain. Similarly, in the glioblastoma model, the increase in neuroplasticity marker BDNF in tumor tissue, which was decreased by thymoquinone. And lastly, the antidepressant effect potential of thymoquinone was, of course, proved to be due to its anti-inflammatory activity, which remained independent of neurogenesis. We have recently found many different antidepressants which work independent of neurogenesis, which gives a new hope to the sufferers of depression, as well as depression as a comorbidity of cancer and other disorders, other inflammatory disorders. So the conclusion is that thymoquinone shows anti-glioblastoma potential, anti-cancer potential. It also exhibits antidepressant and anti-inflammatory effect, and it depicted antidepressant activity with underlying anti-inflammatory effect in mice model of chronic stress-induced depression, where neuroinflammation has already been proved to be a part. Thymoquinone also showed antidepressant potential and anti-inflammatory activity in orthotopic xenograft GBM mice model. So these there were some single nucleotide polymorphisms also found that support the role of glioblastoma, which have not been included in this presentation. So the future potential, thymoquinone has been termed as a molecule of the future, and because of its holistic role and its effect against cancer and inflammatory settings. So we are working on it to further the understanding of its mechanisms and its effect on this disease disorder. Some of the references, and thank you very much. If you have any questions, I'm here to answer.
Is it on? Right. Thank you very much for your talk. It was very well put together. And with that, I would like to invite our next speaker, Dr. Jacek Grunwald. He is a Nobel laureate in Polish Academy of Sciences. So it's a huge honor for us to have him here today and this opportunity to hear him. He is the professor at the Department of Genetics and Pathomorphology in Pomeranian Medical University in Poland. And he is also the global authority in genetic counseling. And he is also the ex-dean of his department in the university there. So I would like to invite him for his talk. And the title of his talk is Management of Patients with Hereditary Breast and Ovarian Cancer, a Polish Perspective. And because he is a gynecologist, oncologist by profession, so his take would be very, very professional and very important, I think. So thank you very much for joining us. And over to you now.
Is it okay? Okay. I would like to say the story about our research, and so everything started almost 30 years ago when I started to work with Jan Lubiński and the whole team. And at that time, BRCA1 and BRCA2 was not cloned yet. Yes, but we were. So I don't know how it happened, but we decided to make registry. If you don't have the tool, but registry of cancers, it is all the value. And some years later, when genes were cloned in 1994, 95, so we were ready to start our research. And how it happened? Oops. So at that moment in Poland, about 10–15% of consecutive breast cancers have highly genetically determined predisposition. So 4% via BRCA1. We don't have very many BRCA2 carriers, but it is also 0.5%. CHEK2 protein truncation, it is 3%, 7% it is missense, PALB2 1%. So altogether it is over 10%. And in country range, so it is about 300,000 people of carriers. Yeah, so it is a lot of to do. So in 1992, so we started to make this registry. So we collected families with breast cancer and ovarian cancer. And when genes were cloned some years later, so we were ready to have 200 families and to sequence and to see what's going on. And from genetic point of view, so we were very lucky because Polish population is relatively homogeneous, and most of BRCA1 and BRCA2 mutations, there was this one mutation, C61G, the second most frequent, and deletion A in 4153, it was the third most common mutation. And if we take these three mutations together, in this series of 200, we detected 122 carriers and 111 were these three. So it made that we were able to elaborate very inexpensive tests. And at that time, sequencing, it was on the level of $3,000, $2,000. So we couldn't afford. But this test for 3 mutations, it was very cheap. It was about 50, 60 times cheaper than sequencing. And we made a strategic decision that we will use this cheap test, but it will be available almost to everybody. And it was our strategy. So now some more mutations were detected, which are recurrent in Polish population. So we, in our, let's say, panel for founder mutations, there are 13 BRCA1, BRCA2 mutations. So it is a bit more sensitive test. And of course, at the beginning, everybody said that such families should be tested. So strong family history. So I think it is no question such family should be tested, and of course it is no wonder that we find mutation in such family. But also we were finding mutations in family when it was only one case, and we made study on let's say larger scale. We had again 5,000 consecutive cases of breast cancer. We detected 200 BRCA1 mutations. And we asked for family history. And what we found that only 57% of patients who had breast cancer said that somebody in family had additional breast and ovarian cancer. So in Polish situation, almost half of mutation carriers have negative family history. Why? First of all, not full penetrance. Penetrance is about 70%, maybe 80%. So every fourth person who is a carrier is not showing symptoms. And in European society, it is even stronger factor. Our families are small now. So maybe in my generation, it was already 2-3 children at home, yes, but now it is only one child. So no people, no cancers. Yes, so nowadays we are slowly coming to the time where only genetic tests will be able to detect majority of carriers. Yeah, family history, of course, it is a great tool, but we have to know that it is a good tool if family members are, enough big. So we made population screening in our region. Yeah, our region is located in northwest part of Poland. So we were able to deliver such questionnaires to patients. In our region, there are 1.7 million inhabitants. It is about 4% of Polish population. And we got over 1,300,000 questionnaires. About 40,000 patients were elected because at least one person had breast and ovarian cancer, and we made genetic testing. And about 1,000 carriers in early 2000 we detected, and they got some surveillance indications. So similar system we made in whole country. So we organized hereditary cancer clinics in Poland, almost in all regions. It was impossible to make population screening, but each patient who had breast and ovarian cancer had a chance to be tested. So nowadays we have over in our register over 10,000 BRCA1, BRCA2 carriers, and they collaborate. They are coming every 6 months for surveillance, for test, for MRI of breast, or for ultrasound, or mammography, and so on. They have indications, yes. And of course, every 1 year, so they are getting questionnaire and they fulfill about what happens with them, and we register this. So nowadays, indications for BRCA testing in Poland, it is all patients affected with breast and ovarian cancer, all adult females, even now males, with at least one first or second degree relative affected with breast cancer or ovarian cancer at any age. And for NGS, for full sequencing, all patients with breast and ovarian cancer with at least one first, second degree relative affected with breast ovarian cancer, and one of these cancers should be below 50. And recently, all breast cancer patients below age of 45, they have a right to be tested with NGS, yes. So in this system, in this recommendation, so every about 10% of patients who fulfill such criteria, they are detected as carriers. So patients get such recommendation for surveillance. We start in the age of 25 with magnetic resonance and ultrasound, and then other stuff is going on. So of course we have to remember that only ultrasound in a young woman has very limited sensitivity. MRI is much better. Yes, so we put importance into MRI testing, and of course still we don't have a tool which is useful enough sufficient for early detection of ovarian cancer. So that's why our recommendations for prophylactic, it is the most important thing. It is prophylactic adnexectomy. So we should remove ovaries in age of 35 if women decide that children are at home. Yeah, if they plan more children, so we'll wait a little bit. But we recommend to have a children as early as possible to be able in age of 35, 40 to remove ovaries, because we don't have a tool for the detection of early ovarian cancer. But we did studies on all our contraceptives. If they are taken in a young age, below age of 25, so it is increased breast cancer risk. Breastfeeding is protective. All women are recommended for breastfeed. Later menarche, it is also protective. Tubal ligation is protective, tamoxifen is protective, and prophylactic mastectomy is also protective and recommended. And women have access to this. And it is one of our papers, yes, about oral contraceptives. Yes, it was thanks to good collaboration with patients, which fulfilled all these questionnaires. Yes, so we were able to notice that if women take oral contraceptive in age below 25, especially below age 20, and so one year of taking of oral contraceptives in this age, increased breast cancer risk 10%. After 5 years, breast cancer risk is increasing about 70%. Breastfeeding, as I said, is protective. Another study, we have to be careful with chest X-ray in young women, in girls, yes, because it is also increasing breast cancer risk. After age of 30, it doesn't matter, yeah. And we had a question: could we use hormonal replacement therapy after ovarectomy? Because young women after surgery of ovaries, yes, prophylactic surgery, and they are without hormones. And what we found, if hormonal replacement therapy is based on estrogens only, so the risk of breast cancer is the same like women who don't take hormonal replacement therapy. So it is safe. But if we take estrogen, progesterone hormonal replacement therapy, so the risk of breast cancer is increasing. So recommendation is, if woman is coming, young woman, healthy woman is coming for prophylactic surgery, recommendation is just to make adnexectomy and amputation, at least hysterectomy or amputation of corpse of uterus, because then we can give based on estrogen hormonal replacement therapy. And this program works in population scale. So it is Poland in 2001 when we just started to test and no prophylactic surgery was done. So there were almost 8 million women in age over 45. These who are usually affected with ovarian cancer. In our region, it was 350,000. And at that time, we had in Poland 3,167 medium ovarian cancers, and in our region 160 a year. 10 years later, 9 years later, we expected number of women who in this age increase because our society is getting older. The same in our region, but we didn't observe yet the higher number of ovarian cancer, but we observed a lower number of ovarian cancer in our region. We made this population screening. We made already in these 10 years several hundred of prophylactic ovarectomy. Then some years later, we already observed increase in the country of ovarian cancer, but in our region, it is still less than here. And of course, in consecutive cases of ovarian cancer, so in 2000, about 13%, 12.5% were carriers, and now only 7%. So we were able to get to some patients and make prophylactic surgery. And of course, with breast, it is of course much better to be in prophylactic project, prophylactic management, because medium size of breast cancer diagnosis 1.7. If woman mutation is diagnosed after diagnosis of breast cancer, so she didn't know that she's carrier, she didn't care so much, so tumor is twice so big, and look, metastasis to lymph nodes are much more frequent. 60% has metastasis to lymph nodes. Additional genes, yes. So in 2004, so Czarek Cybulski from our group, so he found that CHEK2 is multi-organ cancer susceptibility gene, and it increased the risk of breast cancer, mutation of this breast cancer, colon, kidney, thyroid, and prostate. So these mutations increase risk, not dramatically. It is medium risk gene, but increased. But if family history is positive, look, if there is a woman with CHEK2 mutation and her mother, healthy woman, and her mother had breast cancer, so the risk of breast cancer is odds ratio is 5.7. So in Polish reality, population risk is 7-8% times 6. So it is already almost 50% risk. Yes, 6 times 8, so it is 48. Yeah. So and if there are 2 first degree relative effective with breast cancer, so the risk is even 7. So it is close to this as we have for BRCA carriers. Another gene which was in our population found and confirmed on French Canadian, it is recul. It is quite rare, but also the risk is 5.5 increase. And PALB2 also it was detected as a risk factor. So this 1, 2, 3, 4 genes are detected. Now we also included some BRCA2 mutations. And here we have found their mutations, and in very cheap and fast tests, we are able to test patients. Treatment, yeah. So finally, we were able to also to get to treatment. And you know, in 2006, I was traveling with my friend to South Poland, and we were discussing about his research. And so I had, you know, consecutive cases of breast cancer patients, and we had data, telephone numbers, and so on. And it was 200 women carriers, consecutive cases. And all oncologists, yes, chemotherapists knows that about 25% of women who from consecutive group should have pre-operative neoadjuvant chemotherapy. So we had 44 in this 200. And what we noticed that if taxanes are given, so it doesn't work. But if all the types of chemotherapy were given, it is much better results. And then we found that just paper, yes, on cell lines, that it is resistant, that if it is BRCA cells with BRCA1 dependent, it is resistant to taxanes, but sensitivity to platinum. And we wrote a prepared project, ethic committee, and so on, and we started to give platinum to our patients. And first 10 patients, so we are very happy and lucky. 10 of 10 first patients, 9 had pathological complete response. So there was no living cells in tumor after 4 chemotherapies with neoadjuvant chemotherapies. Only 1 had partial response. Nowadays, we are on the level of 50–60%. Yes, so it is still much better than other chemotherapy. And after many years, we were able to go to survival because pathological complete response, it is one factor. It is a very good prognosis factor because it should be 95% survival, a 10-year survival. But then we were able on prospective study to show and to see how it really works. And if we have women treated with platinum, so 10-year survival, neoadjuvant platinum is close to 90%. Other chemotherapies, it is 60%. If women have oophorectomy, so it is also very important factor for survival, should be done oophorectomy, BRCA carrier. And if not, it is worse. And of course, the best situation is if woman has platinum and oophorectomy, and it is very bad. Prognosis is much worse if no platinum was given and no oophorectomy. So this curves. And according to this, so it was noticed after many years, and our Ministry of Health made 4 years ago recommendation that women with platinum who are BRCA1 carrier should be offered, not for sure, but should be offered treatment with platinum. So in Poland now it is available. And first of all, it is very inexpensive drug. Yeah, nowadays PARP inhibitors are coming into the market and so on. Results are very similar, but price is completely different. Yeah. Impact of oophorectomy on survival for breast cancer in patients with CHEK2. Yes, in Poland it is very frequent mutation, and we wanted to see if we should specifically treat these patients. And it is quite recent study. So we had 839 patients with breast cancer, CHEK2 positive, and 800 matched 839 patients with breast cancer without CHEK2. Mean follow-up 12 years, 15-year survival CHEK2, it was 76.6, survival of control groups 17. So it was well matched group of study group and cases. So CHEK2 positive breast cancer patients and CHEK2 negative breast cancer patients. And look, if it is CHEK2, yeah, if it is CHEK2, so if we make oophorectomy in this group, so survival, it is we can improve 40%. If it is not CHEK2, the same woman, the same tumor, yeah, it is not improving. Yeah, so women with CHEK2 should, especially, next slide. So it is women CHEK2 who had oophorectomy and CHEK2 positive who didn't have oophorectomy. Also 60% better survival for this who had oophorectomy. It should be offered. And it works especially in women in age below 50. Yeah, in age below. It works over 50, but below 50. So if woman is CHEK2 positive and has breast cancer, especially in age below 50, it should be recommended for her to make prophylactic, or prophylactic, it is not prophylactic, oophorectomy, which improve survival. And its improvement is about 15%. Yeah. And another observation about PALB2. Yeah. Also, we have another big group with PALB2, and what we noticed: 10-year survival of women with PALB2, PALB2. Yeah. BRCA1 and PALB2. It is 10-year survival, much worse. Yeah. So we have to be careful with patients with PALB2, and do we have any recommendation? Yeah. So it is chance, yes. If tumor is below 2 centimeters, 10-year survival is quite good. If it is between 2 and 5 centimeters, it's not so good, yes. But if it is over 5 centimeters, so it looks very bad. So first of all, this woman should be recommended with early detection. Yeah. So nowadays we are able also within our ministry program to include them into magnetic resonance, and they are allowed to do it. Yeah, and it is paid. So in Poland we have about 50,000 of PALB2 carriers, and they should be recommended to, ultrasound and so on, and MRI. So there are some papers also indicating it was supported our observations. And general conclusion: genetic testing is a critical in optimization of prophylactics and treatment of patients with breast ovarian cancer syndrome. Time for population screening, yes, in our country. It is the group, yes, and thank you very much for attendance and for listening to me. Thank you.
Thank you very much, Jacek. It was a very, very good talk, and I know that we must have learned a lot of things from here. I would like to address our attendees who are online right now and attending this session. If they have any questions, they can leave those questions in the chat window, and we can read those questions for you from the speakers. So kindly put the name of the speaker that you want that answer from. And with this, we are reaching now to the question and answer session of this cancer research session of the pre-symposium workshop. And we are open for questions now. And if any of you have any questions, please raise your hand so that we can take those questions. And like I said, that all the talks were very, very comprehensive, and I'm sure that you have questions from those, so please raise your hands. Thank you.
My question is from Dr. Hamad Naveed. So you mentioned how if the parameters of the image that your algorithm is processing changes, the performance is also altered. You kind of gave the analogy of a black box. So how often did you find yourself tweaking the algorithm itself rather than letting it figure out the weighted variables on its own? So actually, there are standard algorithms available. So you get the what we call the backbone, where there's some standard values that are given to us that work for at least real life data sets like outside images. But really, there's no one standard for medical images. So you have to tweak a lot because if you look at these whole slide images, there's a lot more data. So outside image, you have a sky, so you have a clear background. That really doesn't matter. So you can figure out the outline of the object that you want, a horse or a guy. It's much easier to figure out. But in a whole slide image, it's completely filled with cells or certain size. So there's a lot more information. So there's not much sort of in the literature that tells us what's a good range for these parameters or how many parameters do you require. We call this the art. It's not actually the science. It's basically trying to figure out things what work in one data set versus the other. So you have to tweak a lot, and most of the time is about trying to figure out what parameter is giving you the edge and why, and then sort of making the algorithm go that way.
Okay. I would like to have also one question to you. Yes, because you are on the level of your, let's say, so-called machine. Yeah, it is how many false positive results you have and false negative results.
So yeah, as I said, the data set is very imbalanced. So we actually have to make sure. So false positive and negatives is mostly in the time when you only have two categories. So positive is when there is cancer, and the negative is when there is, because we were looking at four categories: normal, benign, invasive, in situ. So it's basically being confused. The most of the time, the algorithm confuses between in situ and invasive, or between normal and benign. So which is not that bad because you're trying to figure out one side is cancer and the other is. But there is a very clear distinction between a normal, and actually it's visually very easy to see a normal cell compared to something that's invasive. So I mean, if I make it into two classes, there would be very few false positives and false negatives. But of course, between benign and normal, there will be some confusion for the algorithm, and between invasive and in situ, there will be some confusion. But it's not huge. It's more than 80% accuracy.
So I think it is the chance that soon, at least, we will be able to, let's say, use artificial intelligence that it is, let's say, safe not to watch, and to concentrate on this, let's say.
So I would say that's still a little bit further away. Probably the better use at this point would be to give an initial guess and to sort of focus. Let's say you don't have to look at the whole slide to give you a hotspot. Maybe mark some cells that we think are mitotic, and the pathologist can just confirm. So instead of letting it run on its own, I think it's better for a few years that the pathologists keep guiding it. So the more images that we feed it, the better it gets. So probably a little bit further down the road.
Okay, thank you.
Any more questions? Yeah.
Thank you, Meera. I have a question for Dr. Jesse. What is your take on the use of preclinical models in terms of treatment, in offering the treatment? What is your take on the use of preclinical models in offering treatment?
You mean about platinum? Yes, this okay. So So for us, this preclinical study, it was just inspiration, which drug to use. Yes, because our first study, it was just, you know, comparison of recommended chemotherapy. And at that time, we were also lucky because we had patients not in 1 year, but in some years in this group. And let's say old chemotherapies were used also at the same time. So we saw that, you know, now recommended chemotherapy only according to pathology and so on is not working. And then we knew that it is BRCA1 cancer. So we look at literature, and it was, you know, something like preclinical model, and it was the study on cell lines. Yes, so somebody did it and was harvesting breast cancer cells in presence of different chemotherapeutic agents. So for us, it was, you know, something like, oh, so it is something new, not used in breast cancer. So maybe let's try it. And so it was inspiration of how to do. And of course, it is different story to use it on cell lines and then to give a to patients. That's why, so we had to prepare ourselves, let's say, properly. So platinum was given to patients, but other indications were given. Yeah, we knew that maybe it will not work in let's say in clinical study, but if we didn't try, we wouldn't know. So let's say we were really very nervous when the first patient called, and it was, you know, the lady from a little town. Yes. And she said, oh, maybe you would do a biopsy. And I said, okay, but we have new chemotherapy, and would you? And she said, okay. And the tumor was 4 centimeters. And we gave the test chemotherapy after 3 weeks, next one. And after 2 chemotherapies, the tumor was already soft. Yeah. So we said, oh, wonderful. And but we were waiting for surgery. Yeah. So, but preclinical study, you know, this theoretical study. So it was, you know, the goal. Yeah, it was. We only read the paper. Yeah. So it is the most very important. Yeah. Without that, without literature data, nothing would go on.
Thank you for your answers. I see that Dr. Asim Amin is online with us, and I have a question for him. Your talk was really good, Dr. Asim Amin. It was very informative, and like every year, we learn a lot from you, and all the work is very exciting. I have this curiosity about this work when you administer these drugs to the patients, and then you see a good result that yes, it is working, the patient is getting better. But do you consider all the other factors that could possibly improve the health of that patient? I mean, this could not all be the drug. You know, maybe the patient changed his or her lifestyle and his or her immunity increased. So what other factors do you study along with the drugs that are given to see the health of the patient?
So thank you. That's excellent. So the issue is that we really don't have any replicable data so far to suggest that there are factors that we can change or we can optimize to improve. The most recent thing in that context is, in fact, been the gut biome. So there has been data published looking at particular gut microbia that may enhance the response to PD-1 inhibition immunotherapy. earlier, I think there were a series of 3 papers that were published in Science a couple of years back, looking at the murine data. There have been studies now completed. We don't have clear results as of yet, where patients were treated with or attempt was made to change their gut microbiome by giving them these bacteria and improve outcomes. Yes, so meaning overall health obviously is important, and in that the most reproducible factor is the performance status. Most of the clinical trials did not include patients who had a performance status of ECOG 2 or 3. So you have to keep that in mind. Organ function, obviously, but really we don't have any reproducible factors that we can change. We can't predict who's going to respond. Meaning we have 95-year people who are responding, and we have 26-year people who are not responding. So how does one explain that?
Much for that answer. It was really sort of addressing what I asked. Do we have any other questions from the speakers? Yeah.
I have a question to Dr. Asim. Have you checked the PD-L1 expression at the tissue level before giving the PD-L1 inhibitor to the patients?
So that again has been a hot topic. I don't know if PD-L1 is a true for melanoma and renal cell. We don't, by the way. In some disease sites that appears to be a little bit more important than melanoma and renal cell. All the data that has accumulated, and most of the immunotherapy data is accumulated from melanoma, because that is where this was all developed, and subsequently renal cell. So the PD-L1 story is when you look at the 067 study for melanoma, the response rate for those patients who had PD-L1 expression was a little higher than those who did not. So it was about 60% compared to 50% for who did not have PD-L1 expression. What does that mean? Meaning, are you not going to treat an advanced melanoma, with a 50% response rate, where the previous data is median survival of 6 months with a response rate of 10%? So, so I don't think it can be used clinically. The other thing is that the PD-L1 expression is dynamic. It changes. So if you stress the tumor, the PD-L1 expression goes up. It's been seen if you expose these tumors to interferon, there is stress out there, immunologic stress out there, and the PD-L1 expression goes up. So some of the studies, in fact, are looking at combining those two strategies, for that. But no, I don't think this PD-L1 biomarker is ready for all disease sites. Yes, meaning and even in disease sites where it has been approved for use, now PD-L1 agnostic tumors are being treated with immunotherapy.
Thank you.
I have another question from Dr. Hamad Naveed, if I may. So in our basic sciences research, we have this, pressure to use number of patients. So if you are using, say, for example, 1 cancer patient, you have to use 2 control samples, or this ratio could be 1:2 or 1:3. So we have to have these controls in comparison to the disease patients. Now, what is the story with these patches? So if you say, for example, you have a spectrum of samples like normal, polyp, and non-metastatic and metastatic from cancer disease, do you keep the number of patches same for each representative tissue, or it can be different?
So actually for us, we try to, I mean, it really doesn't matter if they are different, they don't have to be the same. But we need to ensure that we account for the fact that if we make a mistake on the normal, it's not penalized as much. So the dominant class is not penalized as much because we have more sample and this probability of chance of error is higher there. We need to make sure that if we do something wrong on, let's say, the in situ one, where I only had 5 samples or 15 samples, I have to learn from those 15 samples. So we have to make sure that we balance the weights in a way that we are accounting for our performance on all classes. So it doesn't have to be the same, but we have to be wary of the fact that they are not the same and adjust accordingly.
Any other questions? Do we have any questions in the chat window? No. Okay.
Okay, so thank you very much. So thank you for all lectures, yes, and for all speakers. Thank you for joining us. And I think the talks were wonderful and discussion also. So I think we can close the session, yes, and I hope it will be, some inspiration for everybody. Yeah, thank you very much.
Thank you.